my topic today, and I'm like one of those people who moves around when I talk, so no one has ever told me that my voice does not project, however. Um, so my topic today is the Great Resignation in health centers and, post-COVID, or sort of we're still in COVID, and where do we go now? I will tell you, as a consultant, for the first 3.5 years I was a consultant, I was doing operational turnarounds and expansions and all sorts of things that you normally typically expand or expect to do as an FQHC consultant. About a year ago, I started getting a lot of questions about workforce. More workforce, more workforce. In the past 2 weeks, I've had conversations, and examples I will use are not from the state of New York, with 2 FQHC CEOs, one who is experiencing over 100% turnover rate, which means more people are leaving the organization in a year than she was actually able to hire, and another organization that talked about closing clinics and moving to telehealth, not because they had COVID, not because there was restrictions on travel, but because they didn't have staff to support providers. So first of all, the pain is a little bit universal. So I have very texty slides. That's just how I roll. I also want them to be valuable later. We're going to talk today about the combined effect of resignations and burnout. We're going to talk then about the cost of where we are and the real terms, and then taking those real terms and doing something about it. And so that's where we're going to talk about how we can restore hope in the health center model and how we can respond a little differently and become market differentiators when we're trying to deal with workforce challenges as a result of the resignation. These are just some statistics. I'm not going to read them all. There's sources for each one of them. I think probably the thing that maybe resonated with me the most is that 1 in 5 healthcare workers quit their jobs since February of since the pandemic began, since the pandemic was declared. And this was a study done by Morning Consult. That is 20% of the workforce. Us and teachers are quitting our jobs as a result of the pandemic. We lead all other industries of people who, of the Great Resignation, of people who are leaving their job, and of people who are citing specifically stress and lifestyle change as a need to quit our job. The other thing I'll call out is only because I, as a CEO, I remember experiencing this with my docs. 60 to 75% of physicians were reporting depression, exhaustion, sleep disorder, or PTSD from the pandemic. And I think that's really illustrative of really that combined 2 years worth of stress that people are holding. There's some other things that are exacerbating the staffing problem. Again, I like to move around, so I'm going in and out here. There is a license slowdown due to state licensing agency staffing shortages. U.S. News and World Report specifically called out New York State for some of those staffing shortages and some of the delays then in getting sort of new licensed individuals. And this is one of the stories I will tell you. I had a conversation with a CEO recently who said, we're in a more rural area. We raised salaries actually for our entry-level staff from about $13 an hour to $15 an hour. I was feeling really good. I thought, well, we really responded. We're going to be competitive in the marketplace. We knew what the medical practice down the street was paying. We were a little ahead of them. Went at lunchtime, goes through the little coffee drive-through of the local chain coffee store. And as he's ordering his latte, it says hiring $16.50 an hour, FTPT plus benefits, flexible schedules. And he said, I almost like spit my coffee out of my mouth. I was like, are you kidding me? I am no longer competing with the guys down the street. I'm actually competing in the entire marketplace. The impact, as some of you already know, we have salaries rising at a rate that far exceeds our reimbursement, and talk about squeezing the margins. The average rate across the country is 8%. It is as high as 15% in some high market areas. We also know that patients, particularly chronically ill patients who may have felt vulnerable, didn't come into the health center. Now they're coming into the health center and they're more acutely sick. We also know that shortages within the health center mean that staff who do stay are doing more, and that's becoming an inducement to leave. Vacancies are taking longer and longer to fill. One of the CEOs I recently spoke with said they went from 49 days to fill a vacancy to 74 days in literally a 3-month time period. Reduced staff is also meaning that clinical teams break down. I told you the example of we can't do huddles. We're going to telehealth this week because we don't have enough staffing for this particular site. And then we all have this risk of funding loss when the public health emergency ends. Yesterday, the Biden administration did extend the public health emergency to July 16th. And they have committed to giving us 60 days notice prior to allowing the PHE to expire. One thing we do know is that they are making some noise about letting it expire in July. And this is really what I want to share with you. There's a couple of slides, and I am going to read part of this sentence here and it's highlighted in blue because I really think it's illustrative of some of the challenges we have. And this is from Ariana Huffington and Jen Fisher from Fortune. They say people aren't just quitting their jobs, they're rethinking what they want out of life. What people are resigning from is a culture of workism. The idea that we're defined primarily by our work, and everything else, i.e. life, must fit into the increasingly small space that is left. And I want you to take just a few seconds and think about that, and think about your own personal thoughts about work over the last 2 years, or as you've heard other people talking about the Great Resignation. Because it really has caused us all to rethink what is important. I know at my health center, I had a lot of single moms or families with shift workers, where some of the instability with schools closing and or absences just because your child was exposed to COVID would create significant family challenges. And that really led some of my colleagues at my firm, led them to making decisions about, what was more important, the income or having time with their family, and could they live on less? From the Atlantic, and somebody kind of spoke to it, Dr. Mayeaux spoke to this morning. Ed Young did a series of interviews with healthcare workers who were quitting their job. And this is what he wrote, and I underlined this. Healthcare workers aren't quitting because they can't handle their jobs. They're quitting because they can't handle being unable to do their job. Even before COVID-19, many of them struggled to bridge the gap between the noble ideals of their profession and the realities of business. The pandemic simply pushed them past the limits of that compromise. Now, I say this as a former CEO. I say this as a financially oriented CEO. I was always worried about the bottom line. Part of what I did was a financial recovery when I took over my health center. And so this is a real challenge for us because margins are not going to get any easier anytime soon. But if we think about what healthcare workers were telling Ed Young, they're saying, I can't do this anymore. I can't do this business. I wanted to help people, but I can't do the business. These are personal stories from all around the country. Some of these are people that I know. Some of these were people that, as I've been doing some workforce work, I've been interviewing some of the staff of why they were leaving their health center. One person said, "I'll do anything else." And this is a nurse who resigned to go clean houses for the rental homes at a local ski resort. The pay was equivalent. Another nurse said, "I have options." This was a nurse who quit her job to be a nanny for her grandchildren. She has 3 kids. They all have little kids. She's very happy being a nanny to them. We were in New Orleans. That's where I got that last name, Mayeaux, with a family friend. The guy is in his mid-40s. He said, "My med school loans are paid off. I can't do this anymore." He just quit, and he's going back to law school. Somebody else said, "I don't have anything else yet. I'm scared, but it's got to be better than this." This was an engagement I just did in another state where it was literally a single mom who was quitting her job as a site manager for a health center. She couldn't handle the pressure anymore, the call-ins, the trying to cajole staff into doing a little bit more with less. She was over it. And the one that was kind of, for me, the most sad was a brand new pharmacist, 2 years out of school. She quit her health center where she got care as a kid. She was a believer in the health center movement, but she was often working without a pharmacy tech. She was concerned that there was going to be an error made. She felt like she was risking her license, and she made the decision to quit. She now works at a CVS. So now that I've depressed you, sorry about that, right? Yeah, always bring the person and bring the joy. I think there's really actually, and this is what I've been telling folks around the country, there's some opportunity if we understand the Great Resignation and we fundamentally think about changing that workforce experience so that we are a differentiator in the market. And the first thing we have to understand is that the culture of workism, or the sacrifice for work, is no longer the culture that we can sort of try to adopt and force in our health centers. And how many of us did that, right? How many of us, it was a point of pride. Yeah, I worked 14 hours yesterday. Or I saw 34 patients. Or, yeah, I didn't get out of here till after 6 o'clock last night or after 8 o'clock, right? It was a point of pride about how hard we worked. We still want to take time. We still want to take pride in our work, but we really have to understand that continuing to ask people to sacrifice for work when they've just gone through this whole reevaluation period, we run the risk of losing that person. And then the thing and that's what the next bullet is understanding the evaluation process that most people went through. They really started thinking about what is important to me in life. I know that this is across industries. Have had conversations, like I said, we're in New Orleans around the holidays, and everybody, teacher friends were saying, I don't know, I've got 14 months left until I can retire. Maybe I am retiring. And then we want to create work structures that start to value life outside of work. And again, I tell you this as a CEO that had to worry about churn and burn. I think for many of us, the idea of that transition to value-based payment and that we were going to get paid on quality versus quantity, it didn't really deliver. And we're really still relying on that fee for service and that PPS. And And there's pressure to churn and burn. But if we don't do this, the peril is if we don't start to rethink how we do healthcare and how we do employment of healthcare individuals, we may face even greater shortages because there are going to be people and competitors that may become differentiators. So how do we make it better? One of the things is restoring hope and that sense of connectedness to community. And I think we just heard it with the panel. We also heard it with Samantha's presentation, where we were talking about people need to be motivated by something that is important to them. And being a part of a community and being a part of a solution. So really focusing on positive activities that you can do. And so a couple of ideas. One is to focus on a patient care improvement or workflow improvement where you're really asking frontline staff to help design. And I used to have this rule, and it was a 3-part rule. If it's good for the health center, it's good for the patient, and it's good for the staff, let's find a way to do it. That was sort of the rule. Now, sometimes it wasn't good for the health center because, there were some financial pressures. But that was engaging staff and helping them to have a little bit of control over their workflow and their work life is going to make their employment so much more engaging with you, and it's not going to be as stressful. The other thing, and I have a health center that really engaged around this concept of re-engaging community. And what the CEO said to me is, and this is actually a rural health clinic, it wasn't an FQHC, they said, we're rural, we had to be engaged with our community, and when the pandemic hit, we all went into our silos. And so everything was telehealth. Somebody just used the example of closing your thrift store, right? Well, we had those care coordinators that would take people to the thrift store, and we had those care managers who helped people get housing and would actually drive them, although they weren't always supposed to be driving them, but they drove them to the housing site, right? And that all got lost, and everything became a Zoom or a telephone call referral during the pandemic. And now they're actively re-engaging community. They're actively getting people, their staff, they're encouraging their staff, go see people. It's okay. We're going to be vaccinated. We're going to follow social distancing protocols, but we need to be re-engaged with our community. And so that's the other thing, is to create those opportunities. One strategy I've seen is to actually, if staff want to donate their time to a particular charity or initiative that aligns with the organization's mission, and you can do this, you can sort of provide staff a PTO equivalent for donating their time. So if somebody is a Girl Scout leader and they donate their time, you might be able to say, you might have to put some boundaries and some guardrails around it, but for every 4 hours you donate, we would be willing to give you an hour of PTO. But it's something that says to the employee, I value you outside of this work, and I want to encourage you to have a life outside of this work. Because if an employee does not feel heard and they don't feel that their organization wants them to have a life, they have options now. People are quitting their job. The market is getting tighter and tighter. They don't have to stay with you. The other thing to do is really start emphasizing quality of life. Workism is dead. I think we should all celebrate that workism is dead. I remember, there was a time professionally that the whole idea of work-life balance, those people got mocked, right? Oh, they just don't want to work hard. Now we understand those people that really wanted to emphasize work-life balance, they actually kind of knew what they were talking about. So I think some things that you have all talked about today: embracing remote work, embracing flexible hours, really thinking about, do I need that mom to be in front of her computer from 8 to 4 when school gets out at 2:30, and gosh, she'd really love to pick up her child. Actively explore shift work, allowing people to work different hours, and then job sharing. One health center that I have been working with, they had that same issue, right? Where there was not enough MAs and LPNs, and there were more providers, and they were trying to, team. And so they did. They ultimately, a couple of them came to HR and they said, why aren't we allowed to be part-time employees? Like, 3 of our buddies left because they wanted part-time work. Why can't we be part-time? Why can't we get, why do I have to stay full-time? And the first knee-jerk reaction was, oh my God, if we let these people go part-time, we're going to be even shorter than we are now. And they took a chance, and they let those folks go part-time. And what happened was they were able, and one of the things they said was, if you have friends who are willing to work part-time, let them know that we're going to offer this. And they were able to get a lot of part-time workers. It did take a little more work. Schedules are harder to do, but they were able to really kind of create family-friendly part-time jobs. With clinical staff, one of my health centers, and I think this is one of the coolest things I've seen, they were having a tough time hiring docs, so they went out and they recruited retired docs to work part-time. These were people who were not financially motivated. They had made their money in medicine. They wanted to give back. They were willing to mentor other either younger physicians. In this case, they used a model with PAs and NPs who had just graduated. And so, and it was interesting because some of these folks only wanted to work 1 or 2 days a week, or, they wanted to be snowbirds. The one guy, I think, said something like, I leave on December 26th and I don't come back until May 1st. But with the advent of telehealth, he could still mentor this PA. They could still manage a panel of patients together. The PA felt more comfortable and felt like they were practicing more safely because they had this physician that they could go to. And then improve benefits to take pressure off of salary. And when I say improve benefits, health centers tend to have pretty good benefits in and of themselves. What I would do is look at generational type of benefits. Younger staff on their parents' insurance may not always want health insurance. So giving them an equivalent stipend that makes them earn a little more money so that they can essentially, buy that car or move out of mom and dad's house. That is a great generational benefit. On the other end of the spectrum, working with older staff to do structured retirements is another sort of generational benefit that you can start to deploy to help get that staff to stay. The last thing, and we don't talk about this enough and we don't value it enough, but it really is make work fun again. The Harvard Review did a study and said since the onset of the pandemic, 53% of employees report feeling more exhausted. And, I would just do your own gut check. Are you feeling more tired from the pandemic? Are you exhausted? I think our colleague from Sun River just said, people came back in the office. They were so glad to have connections and see humans again. One of the things we did to keep everybody safe is we stopped having lunches. We stopped having in-person staff meetings. We stopped doing company picnics. We stopped all of these things of bringing people in a group together. But when I look out today, you are all in a group together. And really thinking about that, you were comfortable here. Now take the temperature of your staff, right? We want to respect where people are in terms of recovering from the pandemic, but re-engage in these activities. Re-energize employee recognition programs. If you are not recognizing your employees regularly, that is absolutely critical. You have to re-engage. And if you take nothing else from what I say today, take this message. It is free. It is just an investment of time, but institute and maintain leadership rounds to build relationships with staff. One of the things that Samantha talked about was really validating where people were, right? One of the things that can happen, particularly as we all went into our offices and shut our doors, is staff feeling like leadership knew where they were coming from. Leadership understood how hard it was, right? And the thing is, you have to get out there and be where staff are. You have to, if it's just saying hello, it's really easy to hunker down. If people are frustrated because they're working short, right? It's really easy to not want to go and say hi at the nurse's station and how's everything going today? Because you're going to hear, well, we're down 2 nurses and we're running 4 providers. And, it's absolutely crazy here. But acknowledge where they are and at least they feel heard. Because if you stay in your office and you don't see them when they're going through hard times, that staff is more likely to leave because they don't think you care. So get involved. It is low cost. It is practically free. Get out there and be seen. I used to always have lunch with my staff in the lunchroom. That was one of the things. I always did lunch in the lunchroom. I mean, I had an executive coach who said, well, maybe they don't want to sit with you. Have you ever thought of that? And I thought, no, they want to sit with me. And maybe they didn't. But I really did feel, and it was important to me that my executive team and me, my providers, that we were all seen in the lunchroom because we were all human together. We were having a common human experience, and we needed to be together. And then, as appropriate, engage back in those lunches and those picnics. Do those things that let your staff talk to their friends through their peers who are their friends, right? Because if we don't do that, they're not going to have the personal relationships, and it's really easy to quit your job when you don't have the personal relationships. A couple of other things. If your staff is totally remote, make sure you're doing these things, and it is advisable to try to get staff once a week, once every 2 weeks, once a month together, because we want to keep them building relationships. We also are trying to reinforce our culture about who we are, what we are, how we deliver care, and getting those folks back in the room and creating that group culture is really, really important. And now I just lost the other thing that was in my brain. And it was around social activities. I think it's been said a million times today, but just also establish a cadence of communication and, use all methods of communication available to you. Make sure that your frontline managers, that your director level, your vice president level, all of those folks understand that communication is a key responsibility. Evaluate on that. Send out emails, send out Slack messages, meet on Teams, but get out in front of people and communicate regularly. The last thing I would say, and I heard a little bit of it today, so it was really good to hear some of it, is broaden. The market is so tight right now that you are competing for that same MA. I heard somebody describe a bilingual LCSW as a unicorn. And the psychiatric nurse practitioner, she was beyond that. So one of the things that I am encouraging people to do is start to challenge some of your ideas about what it means to be qualified to work at your health center. I just worked with a health center that had never hired DOs before, only MDs, and saying, you really need to broaden that experience. You're cutting off an entire market. This health center also did not use PAs. And again, cutting off an entire market. Some health centers are using EMTs to room patients. Want to talk about somebody who can do a really great patient interview? It's an EMT, right? They're used to this. The health center that implemented this that I'm aware of, one of the things they found was that this was a completely untapped market, because the EMTs had been on the front lines of the COVID epidemic and they wanted out. They wanted to still make a difference, but they didn't want to be doing that anymore. And this was a way to earn a living wage, practice community medicine, still use their trained skills, and really start to kind of make a difference. Other health centers have started partnering with MA programs to be the clinical site rotations. MAs are also that sort of unicorn. Whenever you can, offer those teaching rotations for those clinical sites. A lot of those relationships went away during the pandemic, so the schools are now interested in reestablishing. So this is your opportunity, if you had been closed out before, to engage those schools. The last thing, and it isn't my favorite thing, but I think it's a real gap filler, is there are these e-health consult startups. Like, my grandmother's saying you can't swing a dead cat without hitting an e-health startup right now, consult startup. I know it's a terrible saying. It's a little generational thing there. But they are actually quite good in limiting some gaps of care. When we think about some of the things where we really need those specialty services, psychiatry, gastroenterology or endocrinology, some of these dermatology, some of these e-consult groups at least get your patients access to care. And so what the future looks like, and I kind of say it all there, is the truth is we don't know. What can we expect? I think we're going to continue to experience pressure to find qualified staff. I think we also have to consider the long-term effects of the pandemic, overwork, and that sense of unappreciation or underappreciation may have long-term impacts on the next generation of healthcare workers, right? How many nurses do you have tell their kids, be anything other than a nurse? And so we really have to think about, we are going to be 1.2 million nurses short by the end of this year. How are we going to engage and create that enthusiasm for this career? So I think the key here is if you adjust, get creative, and then plan to develop the future workforce, think about things like pay bands and leadership programs to help train entry-level positions into leadership roles. Don't underestimate the power of leadership programs. People don't quit the salary, particularly first-year flight. When you look at that, people who leave within the first 365 days of employment, they had just agreed to the salary. They're not quitting on salary. They're quitting, and the top 3 reasons people say they quit: pay, manager, and training or orientation. Invest in training your entry-level managers. Teach them conflict resolution skills. Teach them de-escalation. Teach them motivational interviewing and empathy. Teach them how to help others be successful. Teach them trauma-informed care, as Samantha was telling us earlier today, so that they cannot devalue those employees. They just took that job 6 months ago. They're not quitting because of pay. They're quitting because the environment isn't what they thought it was. Invest in onboarding. My personal opinion is if you're bringing somebody into an entry-level role at a health center, either an MA or a patient service rep, and they are not being oriented for at least 3 weeks, you may be shortchanging the process. I told this to a CEO who was onboarding for 3 days. This particular, she said, I don't know how we can do that, right? We're so short-staffed, I don't know how we can do that. And I said, you're going to keep being short-staffed. It's not going to fix itself, because their number one reason for leaving and first-year flight, we parsed out the data, their first-year flight, why were people leaving? Number one reason, I didn't know it would be this hard. It's too hard. People are mean. You get yelled at when you make a mistake. I didn't know how to do, I didn't know how to use the EMR. I didn't expect this. People were quitting because of onboarding. So just really get creative. This is the time to explore and get creative. Get creative with benefits. Consider generational benefits. Consider flexible work environments and part-time jobs. Really understand and really put yourself, do your own gut check. Where are you coming from as a result of the pandemic? I am somebody who just told my firm that I'm going to start working less as a result of the pandemic. Realize where you are. Use that to understand where your staff is. And so you start to build structures around them that allow them to stay at your health center.